Hi, everyone. Happy Tuesday to all of you. We are very lucky to be blessed with the presence of Dr. Mariano Palena. He's a vascular surgeon in Italy, in one of my favorite places on the planet, in Abano Terme. And it's just the hot springs are incredible there. So I would imagine Dr. Palena, following any procedures, just head to the hot springs, head to the hot springs for some healing. Maybe not just for the patients, maybe the doctors and clinicians as well. But welcome, welcome, welcome. One of my favorite places on the planet. But also, you know what, Dr. Palena, and I'm sure you've heard this in a million times, but you're right there also in Padua, Padua, and you treat PAD. So it seems, go get treated for PAD in Padua. It just makes sense, right?
Yeah, well, thanks for your kind invitation. Thanks to everyone to take your time to participate. Yeah, as you said, I work as well, I'm not a vascular surgeon,
Oh,
really. I'm interventional radiologist,
interventional radiologist.
but I think today it's almost the same. We are all dedicated for endovascular treatment of peripheral arterial disease and diabetic feet. And yeah, even if with different specialistic education, we are all dedicated and passionate for that. I work, as you mentioned, in Abano Terme. This is my principal hospital, even if I start a couple of months ago to work even in Spain, in Marbella, with a partnership with a vascular surgeon clinic there that want to grow and to learn about peripheral arterial disease therapy. So actually, I'm managing these two places, yeah, trying to be as much as possible in both, trying to continue giving all the needs for our patients as well for the people that want to learn and to grow in this topic.
It's interesting. Do you still find a lot of resistance to learning the new advanced tools and techniques for limb salvage, in particular, creating those smaller vessels in the calf and the foot?
Well, specific patients with foot arteries with isolated foot artery disease are not so frequent. We have many of the since we treat diabetic patients with the diabetic foot. And yeah, I can say there is a resistance. What I can imagine or what I can face every day is there are a group of people that really believe in the treatment of those patients, that really believe that those patients need a treatment and that we can succeed and we can provide a better outcome and a good result for those patients compared to other ones that just they refuse to believe because probably they are not able to do this type of procedures as well. They cannot manage 360 degrees all the situation of those patients. But I cannot imagine about the resistance, just people that since they are not able to manage those type of patients, they decide to refuse the therapy for itself.
Do you find that taking place in Italy as much as we do see that here in the States and in a lot of areas of Europe?
Yeah, it happened everywhere around the world, I believe. It happened even in Italy, in which the country in which we have many physicians dedicated for CLI and for diabetic foot. And most of the vascular community in Italy know that we are dedicated for that. But even though we receive many patients with for second opinion, with first opinion, that was amputation, even if many other colleagues know about us. So yeah, it happens. It's normal. It's the same situation even in Spain. That's the reason why I'm a bit moving to that to help colleagues to grow. And yeah, we receive many patients with very late diagnosis, people that have been looking for a second opinion since the first opinion was amputation.
What do you think it's going to take for a meeting of the minds on both sides, those who do believe in treating below the knee and into the foot versus those that don't believe in treating below the knee and into the foot, when they're continuing to say, well, show me the evidence, show me the evidence. And in my experience and in my opinion, some of the folks that are participating in some of the studies that are arguing for the limitations of the doctors that believe that they should not treat below the knee and into the foot, the ones that are part of those studies are not the ones that should be participating because they may not have the advanced skills to be able to do that. They haven't done as many successful procedures as in your case, or in your partner, Dr. Marco Monzi's case, or in this small community of so-called CLI fighters who perform these on the daily basis with so much success.
Well, yeah, starting from the last part, we perform this type of procedures on the daily basis. I did 5 procedures of this type today before to meet you. I think, yeah, for sure, science is science, but not always is so a real world, let's say. If some people
well,
that
it's only as good as the doctors that are participating, and as you know, not everyone has the same skill set just because they have the title of doctor. And I'm saying that doesn't mean that they have the right skill set for every single situation.
yeah, exactly. I fully agree with you. In fact, I'm dedicated for diabetic foot because I'm not able to do any other thing. So anyone must to dedicate to some specific things and speak about what is their a specific topic or this specific treatment strategy or disease management. For sure, there is a lot of resistance in the group of the no believers, and they push too much to say that well, it's so expensive, the results are no guarantee, and so on. But finally, the evidence today is not so big, but we have evidence that allow us to show, and evidence from US as well from other countries around the world that show us that finally we reduce amputations, we increase the quality of life, we reduce death related to amputation, and we can finally improve the quality of life as well for the patient as well for the families. So I think for those no believers today, they need to start to think about something different because the evidence actually available support the endovascular treatment on the revascularization, even in some cases in which it can be performed by surgery. The evidence supported the revascularization strategy in CLI patients.
And I think we're going to see this movement from patients because even today I ended up with Douglas here who had a question right along those same lines. And I thought, wow, you know, the patients are getting smarter and smarter and smarter, and they're going and doing their own research, and they're actually finding those YouTube videos and they're finding the studies. And I get asked almost every day about pedal loop revascularization as if it's like this new grand, you know, aha, whoa, this is amazing. And, you know, hey, do you have a doctor that does this loop procedure? And even Deborah, who's in our live studio audience, had actually kind of be, Kim, you know, there's this new procedure. It's called the loop procedure. I'm like, yep, you know, it's been around for a while. We just got to get more doctors doing it. But Douglas here, Douglas, share your question with Dr. Mariano Palena.
Thank you for joining us very much. We appreciate
pleasure.
it. But I was wondering, do you ever sit back and wonder what is going through the minds of doctors and other countries who are arguing for their limitations? Do you refute why they refuse treatment for patients below the knee and into the foot instead of choosing amputation, saying saying to why they delay the inevitable? That opening up those vessels will only lead to a revolving door of treatment, because we hear that a lot. It's a revolving door, and it's
Yep.
not
So
worth
why
it.
do it? Yeah. So just amputate instead. Let's just, why delay the inevitable? That's a good question.
Well, I think the question is excellent, and we receive this type of question really frequently, many times in the meetings and even discussing with patients. Honestly speaking, most of the physicians that refuse to treat patients below the knee and below the ankle, I personally believe it's because they are not able to do this type of procedures. It's easy for every person to say this is not functioning, this is not good because you are not able to do that. But it's not a good answer for the patients. In the other hand, let's say that for many no believers, doctors, below the knee and below the ankle is a very challenge procedure, time consuming, device consuming, and finally, those vessels are going to be occluded again. This is the natural history of disease. What happened? The vessels are diseased. We cannot remove the disease from the arterial wall. So since the vessels were occluded once, it cannot be occluded again and again. So there is any real indication to do this type of procedures? Yes, there is, because we are going to open those vessels and to try to guarantee the patency of those vessels as much as possible to guarantee infection healing, ulcers healing, surgical incisions healing, reconstruction of the foot, and finally, those vessels gonna be occluded again, but the foot will be in a new balance, in a new equilibrium, in which even with occluded vessels, the patient is not gonna be more symptomatic.
Right. The whole key with these is to heal the wound, get the patient back on their feet. So when it does occlude again, they will have been walking at that point to build those collateral vessels around those blockages that are, or the narrowings that are in the foot.
May I say one thing about that, like the amputation part? We talk about this a lot. We hear it a lot. For me, I'd rather do 2 procedures a year and keep my foot for as long as I can.
Well, yeah, I mean, this is the idea. The idea is not to repeat the procedures frequently. The idea is to have the chance to maintain the patient out of the cath lab as much as possible, but in their feet, walking, doing a normal life. So the process, I like a description that one diabetic foot surgeon used to do. It's like a cancer. CLI is like a cancer. It's difficult to remove it completely, but it is possible to have a remission. Okay, so the patients are not going to be healthy about peripheral arterial disease, but they are not going to win the battle, but they are going to, we, patients and physicians, we are going to obtain a remission process that could guarantee the patient a good balance, good life, good quality of life without symptoms, even with the peripheral arterial disease. We cannot change the natural history of peripheral arterial disease, but we can change the symptoms of this disease. And for those physicians that believe in amputation, going back again, is that because procedures are time consuming, device consuming, need to call the patient back maybe 2 or 3 times in a year to finally succeed. And when they used to do a cost effectiveness analysis, they used to say that amputation is cheaper. That's really not true, because it's cheap for the hospital, but it's not cheaper for the patient, for the family, and for the society. So for sure, we must invest all our effort and the healthcare system money to avoid amputation, because finally, even if amputation is the faster way, it's not the best way, it's not the better way, and it's not the cheapest way.
Yeah, definitely. And those doctors that are arguing for their own limitations and who are refusing to treat below the knee, one of the things that I will agree with them on, is that they're putting their life in a sense on the line for these patients who are CLI patients that are just going to be back for more and more, because you spend so much time. It takes hours to get through some of these complex lesions. It's like eking your way through this rock hard, these boulders, this calcium that's in there to try and get just that much more blood flow to heal the wound and get the patient back on their feet. But you're exposing yourself for hours on end, patient after patient, day after day, to radiation, which there was even a movie that came out here, a documentary that came out here in the US on this radiation exposure and the risks that these doctors are taking in these procedures, such as yourself.
Well, yeah, this is true. We must consider that interventional radiologists have been exposed to radiation from many, many years. It's quite different from vascular surgeons, but cardiologists and interventional radiologists are more friendly with this situation. And we really know that we must to protect. That's the reason why, again, hospital and physicians are investing in new devices to protect ourselves, like new X-ray protection, new health protections, new title protections, etc. So, yeah, it's a problem. It's a real problem that we know, and we must be very conscious that we need to protect. But I think as well as for the devices available for CLI treatment, as well as for the technical advancement, we have even good development with X-ray protections. So it's a good way, and it's the way to continue following.
And I know here in the US that there's an extra certification that interventional radiologists have to get for radiation safety. And that is not the case in any other practice that is treating PAD, whether it's vascular surgery, or I'm surprised actually interventional cardiology doesn't have that same additional certification for radiation safety that IRs do. Is that the same over in Italy?
No, it's not. It's not.
Oh.
In fact, it's very strange. In Italy, as radiologists, we were at the beginning the only people available or certificated to be X-ray exposed, because we take many courses of X-ray exposition and protection and so on during the specialistic degree. Finally, with the changes and during the time, for cardiologists and vascular surgeons, those courses were also available, and they were obliged to follow these courses to be prepared. And yeah, they have the same certification and the same capabilities as well radiologists. So same rules for everyone.
And Marcia has a question. Marcia, what's your question for Dr. Palena?
Yes, Dr. Palena, good afternoon here from Florida.
Good afternoon.
I'm curious, as a retired X-ray tech, I had to go through the same drill. We had to wear dosimeters that measure how many rims of X-rays you're getting. And I know people that were in special procedures and in fluoro, they get more dosage too. And at least in Florida, where I live, if you get a maximum life dose amount, you're done. You can't work anymore. Is that true in your field in Italy as well?
It is. It is. That's the reason why the hospital invests too much money to change the fluoroscopy machines, the angio machines, to use flat panels, low dose machines, new protection devices, and so on. And they are very strict with dosimeter, dose, and so on, because, yeah, if we achieve the maximum level of dose, we must stay at least 3 months out.
Interesting.
Yeah, it's the dose is not limiting you for the rest of the life. You need time out to like a disintoxication. I don't know how to explain, but
Right.
yeah, you need time to be free of X-rays in the way your cells and your body is able to regenerate as much as possible. But yeah, all the hospitals are very straight with this, and they take care about dosimetry. And if in any way you are uh, going up to your dose, they call us, they oblige us to do any physical as well as biochemical control, laboratory, ultrasound, and so on. And yeah, they advise us to be more protected or to do less procedure for X time to avoid any risk.
And Dr.
So,
Palena, what do you think about the new robotics where you could actually sit in the control room and control the wires, balloons, and catheters and stents, all with a little joystick?
I saw
Have you
that
been
at
able
the
to try
link.
them?
Yeah, I was trying it at the link this year. I personally believe it's incredible. It's amazing, and probably it's gonna be in some way. I don't know in which way, but in some way, it's gonna be the future of interventionist because yeah, it's gonna reduce too much any type of exposition. It's gonna be more time consuming probably to do a procedure, but yeah, very smart. Idea, and in the future it will allow us to reduce any type of exposition as well, to be more relaxed, to be more concentrated, and so on. So I think it's going to be the future.
Yeah, there was one I got to test out that had this amazing haptic feedback where it's almost like when you touch your phone and you press a button, you can actually feel it. It was the same thing in one case where they said, "Okay, do you feel that?" And I said, "Yeah." Well, that's the feeling they said of really soft, thrombotic plaque. And then they said, "Okay, can you feel this?" And they're like, "Okay, that's the rock hard calcium." And I thought that that was absolutely amazing that
wow.
they've advanced that much.
Yeah, it is. It's incredible. They are doing a lot of development and a lot of technology investment to develop some tools that will help too much in the future.
I have
Marcia, yes, I was just going to ask. You've remained unmuted, so I assumed you had one more question for Dr.
Yeah,
Palena.
back to the radiation. When you first decided that you wanted to be a vascular specialist, were you aware of the radiation risks going in?
Yeah,
And
sure.
my second question is, have you or any other doctors you know been put on timeout for radiation exposure? Does it happen frequently?
Well, when I decided to start to do interventional radiology, for sure I was aware about radiation exposition. I was studying radiologist, so any year I had to take courses about X-ray protection. It's from the beginning of radiology way. You study radiation exposition, risk, etc., etc. So for sure I was aware. And I think today in Italy and all around the world, everyone is aware about X-ray exposition. There is more consciousness about X-ray exposition. Everyone knows that if you take a flight, you are exposed to radiation.
Mm-hmm.
So we know that in nature we are exposed to radiation, and X-ray exposition out of the natural exposition can create some problems and issues. We know how to protect and so on. So as I said, yeah, I think it's a risk, but more than anything else, it's important to know it and to go ahead in the correct way, protecting yourself and protecting the patients.
I think that this whole conversation just reaffirms my point earlier that you guys are really passionate, the ones that are true CLI fighters that are on the front lines, saving life and limb on a daily basis. You're true heroes, and we just appreciate you so much for it. If you don't hear that enough each day, we really value your passion for patients. So thank you. I do want to get to some specific questions about PAD and the treatment of PAD. I want to start with the treatment for the common femoral artery, the CFA. There was a debate that I just was participating in on LinkedIn about when to use endovascular versus endarterectomy, which is a surgical procedure where they cut down and they scrape out the plaque and then sew you back up. When a doctor is is deciding whether to use endovascular or surgical, and even from the patient standpoint, how do you know which to do first or when to do it? Do you have any sort of algorithm that you use in deciding whether to send the patient to surgery or whether to perform endovascular with balloons, wires, and catheters? There was one doctor on there that said no, endo should never be performed on the CFA because he claims that the CFA does not respond well to atherectomy, which is, roto-rooting device, or angioplasty, which is the balloon inflation. He says the walls become inflamed, quite inflamed, to quote him, and friable. I'm curious your thoughts, especially with, more advances in tools and techniques today.
No, let's start saying never say never. I mean, it's difficult to say no, and the vascular is not functioning with CFA. Even today, which the advancement and the development of new devices allow us to treat as a CFA in some cases pretty well. So I think it's difficult to say there is a protocol, first time endo, second time open. No, it's not the way. As well to say never endo or always open. It's not the good way. There are some patients specifically that can benefit more with open compared to other patients that can be treated by endo. So my first strategy is Doppler ultrasound and to try to understand how is the flow from the aorta to the CFA, if there are stenosis in the iliac arteries or not, and finally decide, considering the type of the lesion you have in the common femoral. Still believe that coral reef plaques, anterior and posterior wall of the common femoral with no calcified iliac arteries, so clamping can be performed easily and safely in the external iliac and in the profunda, benefit much more from open surgery because you can remove the plaques compared to endo. But those cases can be performed by endo? Yes, sure, but with different results. If you're going to do IVL, so balloon dilatation with the shockwave balloon, IVL lithotripsy,
right,
to crack this calcium in these coral reef plaques is quite difficult to guarantee a good cracking and a good modulation of this common femoral compared to surgery that's going to remove the plaques. For sure, if you don't have an acceptable result, you can finally put a stent, that it can be a good solution, good option. We have very nice results from a couple of trials with mimetic technologies in common femoral providing excellent results. But if I look at the patient like my father or my mother, so stent is going to be the second option in the common femoral for me. So if I have a very sick and diseased common femoral with calcium, coral reef plaques in anterior and posterior wall, I will send the patient to the vascular surgeon for open surgery. If the vascular surgeon said no, because so risk, blah, blah, blah. So for sure.
Well, especially in later stage diabetics, sometimes they don't heal as properly. And it's a really tough place. And we just had a patient that ended up, because I see it all the time with an infection that ended up getting in there. And they ultimately ended up just a couple weeks later after having the ENDART, because of the infection, ended up having an aortofemoral bypass that resulted from that.
Absolutely, absolutely. So if the surgeon refused the patient, I have the green light to go by endo. But still, I must to admit, this is my personal idea, this heavy calcified with coral reef plaques, common femoral, the outcomes are better in the surgery from the vascular perspective. without taking care about comorbidities, problems, complications, etc.
We always say, go ahead.
No, it's for sure if the common femoral disease is different, so no heavy calcification, no coral reef plaques, soft plaques, hyperplasia, whatever. We have many options like vessel prep and DCB, vessel prep and mimetic technology stent, atherectomy. We have many options that allow us to manage in a very good way the common femoral.
And you know, we always tell patients that anytime you're deciding on which procedure to choose, if you do have a choice, we always say to err towards or lean towards a procedure in which there is a contingency plan, because there are some procedures where there's no contingency plan afterwards. You're going to lose your leg. For example, an axillary bifemoral bypass. We've had several of those where the doctors say, well, there's nothing you could do after this, so you're done. Just go ahead and lose your legs and die. I mean, that is what it is. But this one, especially in the common femoral, not that extreme. So my question is, if they choose to do the endarterectomy and go straight to surgical, what are the contingency plans when that fails? Because all procedures do fail at some point.
Well, this is a good point. Most of the vascular surgeons believe that open surgery for common femoral is relatively safe. So complications can be infection in the patch infection, groin infection, and so on. So probably surgeons must select the patients with a lower risk to have complications compared to endo. But I don't think so. They can have so complex or so difficult complications from the vascular perspective that could need a bypass. So, for example, if groin surgery finished in a bypass, the patient selection was so bad, so bad. And I can believe that I was 10 days ago doing a patient with a hybrid procedure. The vascular surgeon opened the groin, did an atherectomy, a punctured the patch, and did the SFA and pop quite fast and safe. So, as I said, planning is 100% of the succeed, probably with hybrid procedure or with an open surgery procedure. It's not possible that you finish in a bad complication in a groin that need a bypass. I can't believe it. So I think it's part of the planning and the decision making.
And if and when the endarterectomy fails, can you go back and do another endarterectomy, or can you do endo after? Because you can do an endarterectomy after endo, but can you do endo after an endarterectomy or redo the endarterectomy, or is it straight to bypass?
No, I think no, straight to bypass is, in my opinion, the last frontier. I can't remember the last time I sent the patient to a bypass for a bypass. I can't remember. So the time you do surgery, you did a surgery, if it's successful, it's gonna be a fantastic result with a very big common femoral that will allow us to puncture in it every time we will need, and so on. For sure, as every procedure, it can fail. If it fails, you're gonna have still a sick, small common femoral with many fibrosis around. So new surgery, in my opinion, it's a must to be avoided. It's not a good indication because it's going to be more complex, more challenging, more difficult related to the previous surgery, the fibrosis, the scar, etc., etc. So probably endo is going to be the second option, and it's going to depend on the type of the result you have. If you can perform an endoatherectomy, endovascular atherectomy of this common femoral, that could be another option that could allow us to gain lumen and to have acceptable functional common femoral, just to go for a vessel prep and mimetic technology stenting.
You keep using the word atherectomy. It's a bad word here in the United States. Every patient is coming to me because of a New York Times article and ProPublica article about atherectomy that stemmed from a Johns Hopkins researcher and vascular surgeon who said atherectomy, the use of it, is leading to amputations. But it was interesting because once all of these articles came out and it created this frenzy, I sat down with both you and Dr. Marco Monzi about the indications for atherectomy, and we put together a well thought out piece on when a patient should expect atherectomy and when it's not indicated. Would you mind sharing some of those indications for atherectomy, or what I liked in your last conference at Click, which they provide this amazing conference every year to teach doctors around the world the most advanced tools and techniques and when and how to use them. You actually have shifted to using the phrase vessel preparation to include not only atherectomy, which is those roto-rooting devices, lasers, etc., the sanders, and the drills in a sense, but also to include IVL, which is intravascular lithotripsy, which is using audio waves to crack the plaque, which you were mentioning during your discussion on the CFA and treating this CFA. So
Exactly.
what are the indications?
Let's start from the beginning. Atherectomy is not the holy grail, but it's a vessel prep device. So it's going to allow us to remove plaques or to micronize calcium, depending on the device you are choosing to use. And it's going to allow us to increase the lumen gain and maybe to increment the vessel wall compliance. So giving back the vessel to a pulsative vessel in calcified arteries. So is indicated in all the patients? No, I don't think so. It's risky in patients without indication. Could be risky, yeah, sure. So when to use it? Common femoral is a nice place to use it, but you must select. For example, all those cases that most of the physicians select from my side are not my preferred. I don't like to use atherectomy in heavy calcified plaques in common femoral because you cannot protect both SFA and profunda, and the risk of embolization is so high. But you have a fibrotic plaque after surgery, yeah, good. The risk of embolization is lower, so some of the dedicated devices can perform well.
And when you say embolization, just so some of the patients understand the risk of embolization, meaning small particles that can go downstream and end up lodging in your toes, or even worse, if they get through your toes, they could lead to a stroke or even a heart attack.
Exactly. This is the definition of embolization. The small particles of tissue that can be soft tissue or calcium can migrate and can arrive to the distality and occlude the previous patent arteries. If it's happened with clots, it's the same name, embolization, emboli, but clots are cells, fresh cells that can be solved with a pharmacological support compared to tissues. Tissues means plaque or calcium that cannot be solved with pharmacological support. So it's important to consider that no any patient have an indication or has an indication for atherectomy. Patients that more frequently underwent to atherectomy, in my personal opinion, are not good option, good candidate for atherectomy because the risk of embolization is so high. I like atherectomy for in-stent thrombosis or occlusion or stenosis. I think if you can protect these vessels distally, is a good option to remove plaque and tissue inside the stent. I really like atherectomy for popliteal artery, these reasons in which, if possible, to avoid stent is good option. So leave nothing behind strategy in popliteal artery. But again, you must be sure that you can protect the tibial arteries with a distal protection device, with a filter.
With a filter, yeah.
Yeah, otherwise, maybe it's better to avoid atherectomy. And you must think about, I personally think about the tissue I have. If I have a heavy calcified artery, or you can use an orbital atherectomy that micronize the particle of the calcium, or otherwise, maybe it's better even with the filter to avoid it. I usually take in account the length of the lesion I am going to treat. If you are going to treat 6-8 centimeters, it could be safe compared to treat 20, 24, 25, 30 centimeters because the risk of embolization increased too much. The same for below the knee and for below the ankle. With orbital atherectomy, we can guarantee excellent result. And small arteries, I used to show multiple cases of below the knee and below the ankle atherectomy in calcified arteries with excellent results. But it's important to consider if we have a patent outflow that will allow us to have a washout during the atherectomy. It's important to consider the technique, how we are going to do that. It's important to consider the speed in which we are going to use the device, which type of device we are going to use. So we have multiple options today. Not all of these options adapt properly to all the patients and to all the lesions. As well, atherectomy is one of them, but it's not indicated always.
One of the biggest mistakes I think some doctors make, and I'm not a doctor, but I've observed thousands of hours of cases, not only in your lab, but around the world. And when I've seen some doctors use atherectomy, it's almost like they think that they need to go 0 to hero and remove as much plaque as they can, as much luminal gain. And here the FDA uses the idea of lumen gain when how much lumen gain do you get using this device? But I look at it and I see more success in cases like yours and Dr. Monzi's, your partner there, that you're just trying to remove that much plaque and get that much more blood flow to be able to heal the wounds and to be able to get a person back on their feet. Less is more, less trauma is better for the patient because less trauma, less use of these devices, using them in a minimal fashion, right? Reduces the hyperplasia, the patient's immune response, where they get all that scar tissue mucking up the artery again sooner. But less is more approach, less trauma, less chance of mucking up those arteries again sooner versus later. Do you agree?
Sure. Yeah, sure. I fully agree. Less is more in some cases, as well as the opposite. I mean, when you have a good indication to reduce the barotrauma, to remove tissue in a safe way, and to apply drugs like drug-coated balloons again inhibit any type of hyperplasia or cells migration, it's the top. It's the best procedure, but you don't have all these indications every day in every patient. So sometimes, yes, less is better, is more, just to manage a patient with a safe procedure. For example, fragile patient in which if you have a complication, you will have many complexity of problems to manage this complication. Sometimes just pass a wire, inflate a balloon, and check your result from the clinical perspective, not only from the vascular perspective, is the top. So as I said, it's difficult to give a straight message, do that or never do that, because we must to tailor our procedure, we must to adapt our procedure to every patient, specifically related to the baseline clinical condition of the patient, related to the vascular lesions, to the extension, to the location, etc., etc., etc.
Yeah, I think that's why we struggle with global standards on this, because it really depends on the presentation of the patient. We do have a question coming in from Deborah. What is new in treating microvascular disease, especially in diabetics? It's severely impacted, she says, by the blood sugars, and they don't always present in the same way as PAD. But even some, such as herself, that don't have diabetes and do have microvascular disease, for whatever reason, she's wondering, how do you treat those patients that don't have general blocked arteries, but they have this microvascular disease that is debilitating?
Well, microvascular disease exists, is related to diabetes. It's for sure less frequent compared to what we have been believing in the past, because if you inject contrast from the aorta or from the groin or from the knee, you cannot evaluate most of the cases, specifically the small arteries in the foot. So microvascular disease is something that exists and we cannot treat. We cannot treat at all. But with the microvascular, I'm understanding vessels smaller than 1 millimeter. It means that I can open tibial arteries. I can open foot arteries. We have 4-5 main vessels in the foot: 2 dorsal, 2 plantar, and the arch. All of these arteries can be treated and can be opened in most of the cases. As well, I can treat even the metatarsal arteries, so the arteries that go straight for every toe. I have multiple cases in which I arrived there with the 1.5 or 2 millimeter balloon. I dilate the arteries for the toe. So after this, what we have, the microvessels that can be not treated. Collaterals of collaterals, vessels that perfuse the skin or perfuse the tissues. Those arteries are the microvessels, and it cannot be treated, and it represents the microvascular disease. For the other arteries, even the small arteries, as described today, SAD, small artery disease, it means the foot arteries, the metatarsal arteries, those arteries can be treated. Yeah.
And what about, let's say, just to at least handle some of the symptoms, what do you think about like a nitro patch or something like that to try and help the spasming that occurs sometimes in microvascular disease?
Yeah, I don't believe in the microvascular disease, isolated microvascular disease. Diabetic patients with the CLI % with the microvascular and macro and micro vascular disease. And in most of those cases, when we open the big arteries, so even the small arteries, but not the micro, we realize that there is no so microvascular disease. And we realize that there are many connections between the microvasculature of the tissues. So at the end, if you provide a direct flow for the forefoot, for a toe, in most of the cases, you have a good chance to have a good perfusion and to improve the perfusion.
So in a
for sure, a combination of vascular procedure plus pharmacological support is the best option today.
So in a patient such as Deborah that presents with her dorsalis pedis being closed off, but no other sign of PAD anywhere, no other artery blockages anywhere else, but in the DP, you would have opened the DP.
Yeah, it's very strange to have a patient with only DP occluded.
Right.
Probably if she has plantar arteries patent and as well as all the tibial arteries patent, she could have an anatomical variation with an absence of a DP. It's present in 12% of the population. So I would like to see an angiogram of the foot in lateral view as well as in anteroposterior view to see if there is an anatomical variation or not. And for sure, if she's not in front of an anatomical variation, I think there is a big chance to open the DP, yeah, if needed, because finally symptoms, clinical indications should, how can I say, should support our procedure.
Yes. And Julie is asking if the duplex ultrasound shows that she has calcium in her leg arteries, why would the doctor put her on 10 milligrams of Atorvastatin? I can never say that. It's the, yes, thank you, calcium daily. Wouldn't the calcium she's asking in the statin add to her current calcifications, making things worse? I hear this type of question all the time.
Well, atorvastatin is cholesterol control, pharmacological control for cholesterol, for triglyceride. So all of these drugs have an effect, a protective effect for the cardiovascular system. So that's the reason why it's used for any vascular or cardiovascular disease. It's not specifically for calcium or no calcium. There are no drugs that can prevent calcifications or can remove calcifications from the arterial wall. So atorvastatin, statins are used as protective cardiovascular drugs.
And we have time for one or two very, very short questions. If anyone in our live audience wants to go ahead and unmute and ask a question. I think Douglas has a question.
I was just curious, for you, are there specific guidelines you choose between how many surgeries you do and going to a bypass?
Specific guidelines? Sorry, I don't understand the question. Can you repeat, please?
Is there any sort of algorithm that you use where you say, well, endo is not going to work or endovascular is not going to work, so I am going to send them for a bypass? What is your threshold? And I would imagine it would depend on the area of the leg and the foot for that.
Now, honestly speaking, very transparent and honest, there is no space for surgery when endovascular fail. I mean, if the patient has a good option for surgery, a good endovascular surgeon is able to manage in the proper way the revascularization. If the patient fail with endovascular, is going to fail with the surgery too. You can believe me, 100% of my patients, of the 100% of my patients, maybe less than 5% could perform a bypass, but for sure, I'm able to do better by endo, less invasive, less complex for the patient, less comorbidities for the patients, less complications by endo compared to surgery. About the patients that I cannot manage by endo, normal endo, because still today we have DVA, deep vein arterializations, and so on, that procedures that allow us to increase the number of treated patients. All those patients that cannot be managed by endo cannot be managed by surgery, because when endo fail is because we are talking about heavy calcified small artery disease. So it means foot arteries heavily calcified that we cannot cross, we cannot open, and no any vascular surgeon can anastomose a bypass to this heavy calcified occluded foot arteries. So when endo fail, and open surgery fail too. When I send the patient for a vascular surgeon for a bypass, as I said, I can remember the last time I did, but when with good threshold could be a patient that you manage a FEMPOP revascularization, you did your DCB and it failed, you put your stent and it failed, you did atherectomy plus DCB in stent and it failed. Okay, maybe before to repeat multiple times, if the patient is a good candidate for surgery and he has or she has a good vein for a vein bypass, well, maybe it's good to, rather than to stay repeating and repeating and repeating endovascular, if you did a good job from the beginning by endovascular and it was not performing well, it's very honest and good option to send the patient for a vein bypass at the second or the third time.
Does that answer your question, Douglas? Yes. They try to send here, at least in the US, and also I know in England, they try to send patients that are on the younger end for bypass. But my question, because they claim it's more durable, and so I hear a lot of vascular surgeons say, well, I want to go ahead for the bypass because it's more durable. We can kick the can down further. But my response is, okay, so you kick the can down further for these younger patients or any patient whatsoever, and you say, okay, well, this bypass is going to last 7 to 10 years, maybe even 20. But if it's a younger patient, so they get to 20 years, what's next? Is amputation the only option for them after the bypass? What are the options beyond bypass? In some cases, yes, they can redo the bypass if by that point the vein is still healthy, and they might be able to use synthetic as well. But a lot of patients always ask me, what are the indications, or when can an interventional doctor such as yourself go in and actually clear out a bypass graft?
Well, for sure, vein bypass is more durable compared to most of the endovascular approaches. What means young patient with good veins. Why vein bypass are more durable? Because it's done from healthy arteries to healthy arteries. This is not the situation with diabetic CLI patients. Diabetic CLI patients, they don't have healthy arteries. They have less disease or more diseased arteries, but all the arteries are diseased. So it's very difficult to have a durable vein bypass in a CLI patient because there are no healthy arteries. For example, bypass is fantastic for traumatic arterial disease. If you have an accident, you broke your leg, you damage your artery, the surgeon take the vein, put the bypass, it's going to be very durable. I saw 2 bypasses from femoral artery to dorsalis pedis, 15 years and 20 years, still patent, post-traumatic. So when you have a healthy arteries, bypass is fantastic, vein bypass. In our population, without healthy arteries, bypasses are not so durable as we have been discussing. For sure.
Yeah, because
for sure, a bypass is still an option. And a patient with a bypass failure after 10 years, 5 years, 3 years cannot be amputated, because what was bypassed 3 years before, 5 years before, can be open after 5 years. We managed to open the native arteries in most of the patients after surgery, doing crazy procedures, even with surgical ligation. We use re-enter devices from below, from above, and so on. We are very, how can I say, inventive guys, and we manage.
I love that.
We manage to open these arteries. So amputation is the last frontier, is the last option, is when we finish every option. And let's say that, again, natural history of most CLI patients is to finally, at some step, finish with an amputation. But it doesn't mean to lose the leg, maybe a toe or a forefoot. But our mission is to help the patients as much as possible to avoid that as much as possible. Even if we know that finally most of the CLI patients at one step will need some surgical procedure in the foot and could lose some tissue of the foot, our idea is to do the best to avoid that, or to protect the patient from any amputation as long as possible. So being conscious that, as I said before, it's like to fight with the cancer. We are not going to heal the patient. We cannot remove the disease, but we must to help the patient to follow the patient in this long way of the CLI, to avoid amputation as much as possible, or at least to delay as much as possible.
Well, thank you so much, Dr. Mariano Palena. We've come up on an hour here. We appreciate all of your time. I want to ask you your final thoughts, and I think a good way, after spending all of this time talking about your role as the physician in care for these patients, what is the role of the patients in their own care and improving their own prognosis with this disease?
Well, the role of the patient is very well known, I believe. Stop smoking, control diabetes, diet, exercise, believe in the doctors, take the medicines, take the therapies. Because today, as you mentioned before, patients are very smart and very well informed, and this is fantastic. So if someone proposes you an amputation, ask a second opinion. By the time you found a physician that is gonna take care of you, follow this doctor. So change the doctor is good option, but you cannot have a good therapy changing continuously the doctor, and you must to follow the doctor advices. So again, exercise, no smoking, diabetes control, diet, reduce obesity, and pharmacological support.
Thank you so much, Dr. Mariano Palena, world-renowned CLI fighter. We really appreciate you. If you have any questions, if you think you have leg pain, tingling, numbness, leg cramps, you have a wound that won't heal on your foot, make sure you do call our Leg Saver hotline at 415-320-7138 or go to padhelp.org. And don't forget to like and subscribe to our channel for more amazing educational content on peripheral artery disease and critical